Thanks. We are extremely fortunate today to have Dr. Weinraub here to talk to us about failure to thrive. He has substantial experience in not only this area, but a lot of different related medical areas. He's a great expert to consider if you need one for any of your cases. And he's done a lot of testimony in this courthouse as well, I believe. So he's familiar with our practices, and that's also really useful. I don't want to step on his toes. I will let him get started.
Hey, everybody.
Hello.
All right. Hi. So actually, I'm a board-certified pediatrician with over 40 years experience. And I worked in Edelman Court from 2001 to 2012, start of 2013, as a senior consultant pediatrician, full-time. So I know the halls, the walls, the rooms, the courts, maybe some of the judges, lots of the attorneys. I did over 1,000 court-ordered cases, and I did probably 3 times that in consults and hallways. So I have a lot of experience just from here. Since I left Children's Court, I've been doing consulting work on shaken baby cases, multiple unexplained fracture cases, failure to thrive, and other forensic pediatric issues around the country. So I've been real busy. When I worked, I wanted to give you a little heads up. When I worked here, my supervisor was a psychiatrist who stated that it was more efficacious and cost-effective to use electroconvulsive therapy than psychotropic medication behind the scenes. That's how bad it was. He didn't say it openly, but he said it to me, and that's his attitude. Then he was replaced by a psychiatrist who said that psychotropic medications were more important than pediatric knowledge, and she didn't need my consulting. So that was the kind of environment that we had then. I don't know what it is now. But we fought, and there's been lots of changes. We set up something called coordinated care, and we worked on all kinds of cases, coordinating them, and I'll explain what that means as we talk about failure to thrive. Failure to thrive, the name itself evokes bias. It's like calling somebody an abusive head trauma case. It evokes bias. Failure to thrive means you failed as a parent. You have to prove your innocence. So we're going to talk about that also, but I wanted to bring it out to you so you can be looking for red flags. Your Honor, this failure to thrive case, as soon as you start using the term, you're indicting, you're indicating that your client has a guilt problem, has failed. So you might consider not to use that. I was asked by Amy to make my talk relevant for ways to understand failure to thrive diagnosis to defend your clients. So first is the diagnosis itself. Failure to thrive is not even a diagnosis. I don't know if you knew that. It's not a syndrome either. It's a physical sign of inadequate nutrition to support growth and optimal development. It's just a physical sign. So it's really not even a diagnosis, and that's from standard pediatric literature. By the way, I think you have handouts. You should keep this if you're doing a failure to thrive case. It'll be great for crossing your experts and working with experts. And it's really the standard pediatric article from the Pediatric Journal. It's 2011, but they haven't supplanted it with another one because it's so good. It's called Failure to Thrive, Current Clinical Concepts. Failure to thrive is a physical sign of undernutrition. Once you get that through your head, then you know there's a framework for classifying the causes of failure to thrive. Inadequate intake, malabsorption, or increased metabolic demand. Just want you to hear the words. You don't have to become physicians or physician assistant or nurses or medical people. But just hear the words so that you can use them when you're dealing in court. Inadequate nutrition, malabsorption, or increased metabolic demand. Those are the things we're looking for. Malabsorption could be a kid that has frequent diarrhea and is losing their nutrition that way. Increased metabolic demand could be a child with chronic infection, like an HIV kid, or another kid with immune deficiency, and their metabolic demand is up because they're constantly fighting infection, or chronic urinary tract infection. I saw failure to thrive also. So there's medical workups are required. And what it used to be, maybe you still use the term in court, organic and inorganic causes of failure to thrive. Do you ever hear that now? Organic causes and inorganic causes. it's not appropriate to use the term, and if you have an expert using it, you have to question them on why are they using an old term. Non-organic failure to thrive and organic failure to thrive. Organic failure to thrive means a medical condition, and non-organic means something else happened. And then they assume that the something else is psychosocial, like there's some psychosocial disability in the family. Most commonly, factors are neglect, indifference, or failure of parenting. Yes, that can happen, but it doesn't mean that it's not remediable also. What's neglected more are the mental health concerns that might have resulted in failure to thrive, and we're going to talk about that in a moment too. Do you know how failure to thrive is diagnosed? It's done by a measurement on a graph. Although life is not black and white, right? So I brought some graphs to show you. There's a blue one that said boys birth to 24 months. If they're colored, if they came out in color, I don't know.
Yeah. They're all black and white.
Black and white.
It does have the title on top.
There's 2 pages to the graph. The first page has length and weight on the left-hand side. The second page has head circumference. I'm not going to bore you with it. I just want you to know this is how it's done. You've probably seen these graphs if you've done any of these cases. But if you look in the lower left-hand corner, it said published by the Center for Disease Control, source WHO, World Health Organization. That's the graph you use. Any other graph is not standard of care. So if they brought you measurements and they said this kid is failing to thrive, you want to see what graph they used. It should be this one. This one is based on a wide average sample of children, not just a certain location. So it's useful for Los Angeles and the rest of the country, for all races. So I wanted you to know that as a red flag also. And this birth to 24 months, failure to thrive itself is pretty much used as a term for 2 years and under. Although senior citizens in a nursing home can fail.
Hey, Mike.
Hey, can't let you pass by without a hug, but I'll do it. I lost my train of thought. Let me see. And Marlene.
Senior citizens.
2-year-old, yeah. It's really not just about a 2-year-old, but that's where they focus on. But you can have a 5-year-old that's failing to thrive, or you can have a 55 or a 95-year-old failing to thrive, and you don't hear much about that. Why a 2-year-old? Because we can focus in on the nurturing and the nourishment that was given by the parent, and it becomes therefore a child abuse related case, or at least a question. In this chart, there's on the right hand side there's these curves, one for length and one for weight, right? If you can follow that. And then there's numbers along the curve. It says 98, 95, 85, 75, 50, 25, 10, 5, and 2. Those are percentile growth lines. And the 50th percentile is the average mean, right in the center. If you can look at the one that I have, it has these dots underneath the growth curve. They're showing that kid is failing to thrive in terms of weight, and then later in terms of length. I don't know how to show it better, but that's the way we'll do it. Remember this, that this graph is just a black and white representation, but we don't know which scale was used. We don't know what time of day the child was weighed. We don't know how accurately they recorded the data. There's lots of errors I've seen in cases from across the country and in this court as well. While we're talking about graphs, there's another one I would like you to see. It's called a preterm. It's one pager. Fetal infant chart for preterm infants. See if you can find that. You should keep these graphs in your file on failure to thrive that you can pull out and look at. But this preterm infant one, on the lower portion, it says 22, 24, 26, 28, those are weeks. So let's say a child is born at 36 weeks. You can check their weight, head circumference, and length to see if they're failing to thrive, if they're failing to thrive at birth. Failing to thrive at birth is called small for gestational age. You'll hear that term used, SGA. So they were born small for gestational age, but they're actually failing to thrive in the womb. And failing to thrive in the womb is called intrauterine growth retardation, IUGR. But it's all the same. It's something that's happened to delay the nutritional development of a child before birth or after birth. IUGR is in the womb. SGA is a term used at birth. Also is the AGA, average for gestational age, or LGA, large for gestational age, which occurs with diabetic babies of diabetic mothers, I mean. I'm trying not to lose you with the terms, but just so that you hear them and get familiar with it. Well, this graph for preterm infants is very useful because you can say a 2-month-old is failing to thrive and he was born a month early. And if you use a standard graph, it doesn't take into account the fact that the kid was born small because it was premature. So you can use this graph. You can say, doctor, did you use a preterm graph or did you use the standard graph? You're saying this child was underweight at 2 months, but I don't know if that's true or not because the child was premature. When we understand the diagnostic process of figuring out what happened to a kid to cause them to fail to thrive, we have to remember the word multifactorial. There's not one cause. There's never one cause. And anybody who says, I found the cause isn't being honest. It isn't true. You can find a primary cause that may be important, but there's all kinds of secondary causes. There's family stresses associated with struggle to gain weight of an undernourished child. Can you imagine what happens when a parent is told by a doctor your kid's failing to thrive? The pressure it puts on the parent is enormous. Hearing that a physician is concerned about failure to thrive may add another layer of psychosocial factors that potentiate the condition. Talking about the graphs, when a child is failing to thrive is when they're below the 3rd or 5th percentile on the graph on more than one consecutive visit. Failure to thrive when the weight is below the 3rd or 5th percentile for age on more than one consecutive visit. So two or more visits. Another measure of failure to thrive that's used is when the weight drops down between 2 major percentile lines. Okay, what's a major percentile line? There are some darker lines. Well, the lines themselves, these lines are called major percentile lines. The darker one is the middle one. But if a kid drops from 90th percentile to 75th to 50th percentile or below that, that's considered failure to thrive by some doctors. So you want to say, what standard did you use to declare this kid was failing to thrive? What did you use to make your determination? Unfortunately, there's no standard uniform approach for kids that are older to determine failure to thrive. Using that standard that I just said about falling 2 major percentile lines, someone did a study of 10,000 kids between birth and 6 months of age, and 39% of these healthy children crossed 2 major percentile lines up or down. So it's really not even good. If they use someone expert uses the standard 2 percentile lines that were crossed, then you can challenge them with that because it's not accurate. It's not scientifically accurate. You'll find the study listed in the Failure to Thrive Current Clinical Concepts article I gave you. There's also the idea of symmetrical and asymmetrical failure to thrive. Poor food intake is a fall off in growth first, then weight, in weight first, then length, and then head circumference. So you look for, if you see a pattern over time where the weight fell, then the length fell, and head circumference fell, that would indicate severe malnutrition. Doesn't mean food was withheld, it means malnutrition. And there could be many causes. Drop off in height without weight usually means an endocrine disorder. So if the height falls and the weight stays within the norms, that's a kid with growth hormone problems, an endocrine disorder, and is not failing to thrive due to nutrition. And if the height, weight, and head circumference drop off at the same time, you have a kid with a genetic disorder. That's a hint, red flag. If on your caseload you have a family with a Down syndrome kid, they have to use their own special growth charts. So if they use a regular growth chart and say the child's failing to thrive, no way. There's other genetic syndromes that have their own growth charts, one called Williams syndrome, another called Turner syndrome. If you have one of these kids that's neurologically handicapped and immobilized, using a failure to thrive chart for them could be could be misleading. They're not moving, they're not eating well, they might be tube fed, and their growth curves may be off, which would be standard and expected.
Quick question?
Yes, I'm open for questions.
So when you say Williams and Turner syndrome, what are some other indications of Williams and or Turner syndrome that we could identify with children?
There's dysmorphic features, but you'd want to diagnose. I'm just saying if the kid came in and they were considering a dysmorphic or genetic syndrome, I can't give you like short stature is Turner syndrome and Williams syndrome. I don't have all the features of it. But if you hear that this is a child with a genetic syndrome, you may find it's one of the cases where they have their own growth curve. Their own curves. Yeah.
I know that earlier you said that we should not use the term failure to thrive. What are some alternate terms that we should use?
Undernutrition.
I have a question. For children who are malnourished,
Yes.
could it be the result of not withholding food, but of just like the wrong food or over-processed food?
Yeah, you could have food allergies, food intolerance, gluten intolerance. You have to have a careful workup. Which gets to my next point. You need a careful history. A careful history isn't just that I fed him and he's not gaining weight. It's very specific about what type of formula, when did you stop breastfeeding, when did you start breastfeeding, what happened with breastfeeding, what happened with bottle feeding, how did you feed the child, what bottle, what nipple, what volume, what formula, who was in the house, what's going on in the house when you're feeding, how are you, what's the environment that you're feeding the child in. That's a careful nutrition history. All of it's important, and I rarely see it on any of the cases. I'm reminded of a case I did here in the court, there in the court. I was called to see a family that was in the mother and the father were regional center clients, and they had twins, a boy and a girl, and they were both failing to thrive. And I saw them, and I knew there was a genetic syndrome. It was Fragile X, and they had feeding aversion. They didn't like things in their mouth because they were so sensitive that they couldn't be fed. And this family was struggling and stressed out, and nobody diagnosed feeding aversion. They thought they were withholding food, but it was the genetic syndrome. I still remember that case. I went out and did a home visit, examined them, took off my shoes to get on the floor with them. One of them crawled up and started mouthing the heel of my foot with my sock on, and I made the diagnosis. Strange story, but true. Besides feeding aversion, there's other oral motor dysfunctions, swallowing dysfunctions, and there's swallowing studies, barium swallows, and people who do swallowing studies. You've seen that in some of your cases, that it has to be done, swallowing studies.
Isn't there a thing for infants with their tongue? Some of them have like a funny.
Large tongue.
Like a tongue tie?
Maybe, yeah.
Frenulum. That's controversial in some cases. In some cases, it's very useful. So I can't really tell, except you go to an ear, nose, and throat doctor, and they can grade it 1, 2, 3, 4, 5 severity and decide whether surgery is appropriate or not. But it's helpful for some cases. It's become kind of a trendy surgery, and it's more the frustration of the mother trying to breastfeed and finding a solution outside of herself or her environment or her relationships, and trying to get a surgery to solve it. Let's talk about the gold standard. The gold standard is to put the child in the hospital, right? Or is it fool's gold? Your Honor, this is fool's gold. Why is it fool's gold? Because you don't know what was done in the hospital, whether they actually, you have one nurse every 8 to 10 hours taking care of a child, pumping food into them, and they gain weight. And that's very different than having a kid at home. So some hospitals now, if you can get the child in the hospital, some will have a 24-hour parent visit. You can have, I know you can't order a doctor what you want, but you can certainly suggest it, or you could have a team meeting where you could ask for it. But in the 24-hour visit, where the mother is, or the caregiver is in charge of feeding the child, you need someone to watch the child, watch the mother, not just leave them alone and come in and say they were here for 24 hours and didn't gain weight or gain weight, but someone who's watching the child feed. The key to this whole failure to thrive is, did someone actually watch the child feeding? Like if you have a treating doctor that's come to court to testify his failure to thrive, they'll ask, did you watch the child feed? What did you see? What did you notice? Yeah.
So if the report indicates while the baby, for example, while the baby was in the home of the caretaker, the baby gained a significant amount of weight, we shouldn't, what you're saying is that we can't leave it at that. We need to figure out whether or not someone else was present during the time of the feeding.
Yes, that's one big one.
Okay, and if nobody was present, then perhaps we should ask the social worker to come in and cross the worker as to how she knows how the child's gained weight.
Right, and the public health nurse,
And the public health.
if there's a home visit.
Okay.
The public health nurse should be trained to observe feeding, and many times they just go out and they just check for supplies, and maybe they check the weight and leave.
Right, I've never seen in a report that the public health nurse has been present during the feeding. I've never seen that.
Me either.
Okay, thanks.
So the gold standard of the hospital doesn't mean because a child gained weight in the hospital and didn't gain weight and lost weight at home, doesn't mean that it's intentional failure to thrive. And there's a lot of investigative work that needs to be done to see. You get the hospital records, you get the nursing notes and see what the nurses actually did, what they said, what they observed. Get the dietary note from the hospital and the social worker note. What did they tell the parent while the parent was on the visit? And you review all of these notes, and then you have a real picture of what's going on, and you can make a clear decision about where you think your client stands and where the case stands. I did one case where the child had a large tongue and couldn't feed and had gastrostomy tube. And in the hospital, the child gained weight, and at home, the child lost weight. In the hospital, they had one feeding tube machine that was pumping the food in, and at home they had another one that was kind of a used surplus machine, and it wasn't working right. And it was pushing air into the kid's stomach, and the kid was crying all the time and difficult to manage. That's an example. So failure to thrive is a diagnosis that includes multiple causes. A general pediatrician is trained to conduct the workup for failure to thrive and rule out likely causes. The process of ruling out likely causes includes developing a differential diagnosis. Do you use that term in court? Doctor, what was your differential diagnosis? You should look it up and make sure you use it. It means, what did you consider? Or did you jump to conclusions? But you can use their terms. Because it should even be in the chart. Show me in the chart where you created a differential diagnosis. It'll be in the assessment section. And frequently it's not there, especially in child abuse cases, especially in abusive head trauma and failure to thrive cases, where it's there and it's not worked up. So that once the differential diagnosis, meaning the list of all possible diagnoses, is stated, then you see if the workup was completed on each of these to rule them out. And that's the standard of care workup. So really you fight the case on whether or not the standard of care workup was done, a differential diagnosis and a careful history was obtained. I was asked some of these questions by Amy, so I'm using it. A general pediatrician, as your expert witness, will tell you where this child's diagnosis is positioned in terms of in the process of the workup, where the case has stalled or where it was left. Was a standard of care workup completed? Did bias take over? The pediatrician will also tell you what additional workup was needed and treatment modalities should be tried. A pediatrician can also tell you about parents' concerns, limitations, skill level, if they've been addressed in the treatment plan or not. If you see an actual treatment plan that addresses not just what formula to use, but skill level, concerns, fears, anxiety level, that's a treatment plan. You're dealing with a human being, right? If a child is failing to thrive due to a neurologic disorder, you may need a neurologist's declaration or statement. If it's due to a cardiac disorder where the kid is having trouble due to a cardiac disorder, you may need cardiological consults or declarations. I was asked, given the expert is not a treating doctor, the expert that you hire is not a treating doctor, what can they testify to a reasonable degree of medical certainty? And they can testify to whether or not a standard of care workup was ordered and whether it was completed or not. So you can get help doing that in your cases. What medical records are necessary in a failure to thrive case? Prenatal, labor and delivery, and neonatal records. Not just labor and delivery if it's a young baby, but prenatal. A lot can be told from prenatal, like the ultrasounds that were done before birth. Prenatal, labor and delivery, and neonatal records. Outpatient pediatric records are critical for any case, even if there's just 2 visits, because you're looking for points in time on the growth chart, height, weight, and head circumference. Yeah, Mark?
Do they do nowadays, I don't know the degree of sensitivity of the, ultrasound or sonography, can they tell already in utero if there's fetal underdevelopment? Can they detect that already?
Yes, it's done by leg lengths, looking at different growth relationships between the head circumference and the length of the femur, and there's standards. Yes.
So that,
They can't tell the causes always, but they can tell.
so if we see something like failure, lack of nutrition, and what we're looking at is maybe an underlying pathology, could whatever expert we get take a look at those as getting closer to birth and be able to maybe not, they could use that as a piece to link maybe a genetic or an underlying pathology?
Yes,
So that's why we
it's a
need
big
it.
piece. When there's more money involved in a case where you can get records and you have time, like in a criminal case, it's done all the time. It's because you need the facts. Also the placental pathology to see what happened to the placenta.
And that would be in not the birth records, but the mother's labor records?
Yeah, labor and delivery.
Good. Cool.
Yeah.
So on that same point then, if our client didn't receive prenatal care,
Well, that's a good point.
can we I know that lack of evidence can't necessarily be used as evidence, but can we possibly, do you think it would be a wise idea to possibly bring that up as something for the judge to consider? I don't even know what that would be, but if a lot of our clients don't receive prenatal care, or they don't until they're about 7-8 months pregnant, right? And oftentimes it's not very thorough, because I know that there are a lot of exams done on women that get pregnant over the age of 35, right? And some of our clients don't necessarily get that, like the amniotic fluid testing. And
Yeah.
I don't know all the medical
Yeah,
terms, obviously.
you got it.
But, so then we possibly use that if our client didn't receive such care as a possibility as to why the child is now failing to thrive?
Although not getting prenatal care is used as an indicator of not being a good parent,
It is.
it also is an indicator of a big black box that we don't really know this child. We don't know why the
Right.
child is underweight.
That's what I mean.
underweight.
Thank you.
And we just don't know. And to make an assumption that the continued underweight after birth is not due to some underlying medical cause is a false assumption. You don't know that. The data's missing.
Okay. Cool, thanks.
Yes.
Is there any correlation, because we're seeing birth records, prenatal records, any correlation with low APGAR scores and failure to thrive?
Okay, low APGAR scores are real important, but they're related to what happened right at the time of delivery, right before delivery. They're more related to whether there was delayed labors and cord around the neck and something else causing problems right at delivery. Or sometime soon before delivery. They're not related to the whole prenatal period of time. Unless the child is born near dead because of some genetic problem. That would be obvious. Yeah, but always have an APGAR score on your cases. It's worth looking it up if you don't know. It's named after Virginia APGAR, that woman pediatrician who had the sense enough, was sensitive enough to assess babies at 1 minute and 5 minutes and to see what's going on with them. So. Family history. For God's sake, these cases that go forward without a family history are atrocious. Well, we can't find the father, we can't find the mother, but we know this family doesn't have any genetic disorder. We know the family doesn't have gastrointestinal disorders. We know the family doesn't have food allergies. We don't know. We have to admit that it's not known, and it's a big gap. But a family history, trying to obtain a family history is really critical. Making an effort, having the department ordered to get a family history. Who assesses the parents' parental concerns? Do you do as attorneys? Do you ask what are your fears? What are your religious beliefs about diet? What are your dietary restrictions? What foods make you sick? Also, excessive medical appointments can cause failure to thrive. Disordered household. Like if you have a baby with birth defects and they're running from doctor to doctor and they can't get feeding schedules all lined up and the child's difficult to feed, might take 2 hours to feed and they have appointments. They can fail to thrive due to excessive medical appointments. Somebody needs to coordinate their care. Economic stressors. Special formulas that are difficult to obtain, that require special orders, are difficult. Yeah.
I'm sorry, can you go back?
Don't be sorry, I'm glad you asked me a question.
Okay. It's just very, okay, I'm just a little confused. Excessive medical appointments can
Yes,
cause a failure to thrive.
yes, if you have a difficult to feed baby.
Explain how I don't get it.
If you have a difficult to feed baby, imagine this, what if you have a tube-fed baby and you have to move the bottle there's a machine to a bag, to a baby, to the car, to the appointment, to the neuro appointment, to the GI appointment, to the pediatric appointment, to the hub clinic. And
I
you
see.
wonder why they're not able to keep up.
So then, with that, maybe then excessive anything, like can cause that, like going to all of your other kids' visits and you're taking public transportation?
Well, that's why you need the whole family spectrum of what's going on.
Okay,
But I make a point of the medical visits because a lot of people don't take that into account,
right.
how stressful it is. I'm not saying they shouldn't go, it should be taken into account and
Sure.
factored in.
Okay, thank you.
Special formulas are difficult to obtain. Have you dealt with that? How do you get them? How do you get them for your client? Do you have any way?
I knew that I was on a case where the clients were supposed to be getting it through their insurance, and then the insurance wasn't
Yeah.
covering the expensive formula, and then they had to try to work with the department to get it.
Right. So all that has to be factored in. Also feeding equipment, special nipples, special bottles, feeding tubes, cleaning equipment for the equipment. It's all difficult to obtain. And then is the home in chaos? Does it require support systems in the home for better feeding conditions? So imagine this. This is not picking on anybody in the room, but imagine this. You're well educated, you're a parent of a baby, and it's your time to feed the baby. And you feed the baby and your cell phone goes off because you're working full time, and it's your time with the baby. And you have an important consult, and you're feeding the baby, and you're on the cell phone. It happens once, it happens twice, it happens 3 times. I've done cases where the parent simply was distracted and wasn't able to give the attention needed to feed the baby. Actually, it happens. Also, it happens because you can give the calories, but they don't result in growth unless there's nurtured care at the same time. You all know that. And that should be common knowledge. You have to hold the baby, rock the baby, talk to the baby, and feed the baby for the baby to grow. They don't grow, they don't gain weight even though you give them nutrition if they're not cared for. That's why prop feeding is not, and it's dangerous, but it also doesn't really help if the baby is only prop fed. You know what I mean by prop fed? The bottle's propped up on a pillow or on a, and the baby's just left there in a crib to suck on the bottle. They don't gain, they fail to thrive. That came out of the orphanages in, I forgot the country, Czechoslovakia. Here?
No,
In China. Oh, Chinese babies too.
I thought Romania too.
Romania, yeah. So failure to thrive has multifactorial causes. It's not such black and white situation.
which makes it
Right?
When you were talking about the growth charts, I think it's also important to understand, to my knowledge, that the growth charts that most pediatricians in the United States use are based on the standard head circumference, height, weight of American babies.
Right.
And American babies, many of our clients come from different parts of the world,
Right.
where when they go to see the doctor, there's abnormality in the growth chart, and concern starts happening because they're looking at it.
It's
And I
true.
can tell you in my own life, because my daughter spent the first 8 months of her life in an orphanage in China, and when we came back to the United States, the pediatrician was like, I can't even find where she is on the growth chart because she is so underfed and malnourished and all of that. But I said, no, she was just a baby and she was fine, and there wasn't that much orphanage delay. So I said, well, why don't we get a growth chart from southern China, which our pediatrician did, and bingo, she was in the normal areas now in a Chinese growth chart, which is very easy to get by the pediatrician. So our clients who come from countries where they are shorter than Americans or slender than Americans, their babies are being looked at by big, chunky American growth charts, and I think we need to be aware that not a lot, I mean, you know, and I had a West Side fancy schmancy pediatrician, and my pediatrician couldn't find my daughter on the growth chart until we got a Chinese growth chart, and then everything seemed to be fine. And then shocking, after a few months in the United States, she too became an American. Yeah. And at 22, she's a real American, you know, regular American kind of woman with American kind of stuff.
She made America
But
really
I'm
good.
telling you, that really taught me, as I looked at the failure to thrive, that's always been in the back of my head, is because even people who have been in the United States for multiple generations, their genes are of gene pools that go back thousands of years that are not going to necessarily match the growth charts that the average American is. So just to be aware of that.
I think it's important, and you should argue that in your cases, and keep it in mind. The growth chart that I showed you is supposed to take care of most of that, but I don't know how specific it would be for like her child from China. The original growth charts that many people still use were from a group of kids in Iowa that were bottle fed and raised on a typical diet in Iowa. Caucasian families from Iowa. And that's the charts that were around for generations.
So
That's the
literally
standard.
corn-fed children.
Yeah, they were corn-fed, literally. So you would challenge that. What do attorneys do that's different when working with me? I make sure they talk to parents to find out what the parents' fears are, what the stresses are, what's going on with their child. Ask the parents if they received cooperative support from the physicians, social workers, and the court. A lot of child abuse cases are actually malpractice cases, hidden under the name child abuse, where the people didn't get medical care that was standard. I don't know the numbers, but I know I've seen many of them. If not, if they didn't get supportive care, ask them what it was that they feel they did not receive for their child. What are they missing? And then report the answers to me, and arrange for me also to speak with the parents. As an expert, I speak with the parents too. What will help you cross-examine the department's experts? Take them through the differential diagnosis of failure to thrive. Okay, so this page, diagnostic classifications and causes of selected examples of failure to thrive. That is the differential diagnosis. It comes from this article though. Not enough food offered, food insecurity in the home, poor knowledge of the child's needs, formula dilution, excessive juices, breastfeeding difficulties, neglect. Neglect's at the bottom of the list. I'm not going to read through it, you can read through it, but I wanted you to know you can use that in cross-examining the expert that the department uses. Have the expert state that the differential was completed. Ask them to list the basis for them stating to a reasonable degree of medical certainty that failure to thrive was due to abuse or neglect and not any other cause. So use the terms to a reasonable degree of medical certainty. Have them commit. Do you use that frequently?
Mm-hmm.
It's important. It's not just a malpractice case. It's having to do with the standard of care that's offered. Yeah.
Does the quality of food make a difference?
Yeah.
So calories, like, is it possible that a baby can be receiving sufficient calories and the parents are feeding them, but what they're feeding them
Yeah. So
is lousy, like based on what they get from work?
you need to see a 3-day history,
Okay.
3-day dietary history of all foods given, liquid and solid,
Okay.
and the source, if you can get like,
So that's something that the department's expert should have definitely looked into
it's
as
a
well.
standard of care.
It's a part of the standard of
Yes.
care. Okay.
Doctor?
Yes.
So some of the,
Hey.
hi, some of our legal experts and some of our other doctors are saying that they are moving away from that to a reasonable medical certainty. And so we've been asking them what's more likely than not. That's the kind of phrase that we've been using. Do you
For
think-
dependency court,
Yeah. Well, actually all across the board.
not criminal.
They're saying they're trying to get away from to a reasonable medical certainty. But do you feel that we're covering it if we go to more likely than not, and really pin the doctor down on more likely than not?
As long as they've done a differential diagnosis and they've ruled out all of the causes. And the problem you'll have is a doctor saying, this isn't a cause and I know it from my years of experience. And you have to qualify their degree of probability then. So then you do the same thing, whether it's a reasonable degree of medical certainty or probable, more likely than not. You want to know, did they look at all the different possibilities? Why isn't this still possible? Well, I know it isn't. I did the exam and it just isn't there. How certain are you then?
Thanks.
Or who did the exam? Or what day did you do the exam? Or was the child undressed when you did the exam?
Why is that important?
Because they may have done a partial, just a look-see. I've done cases of kids with meningitis that were never taken out of their infant carrier and sent home with a prescription for a cold and then died of meningitis because nobody really took the kid out, undressed and looked for a rash, checked for rigidity. You want to know how thorough was your exam with your probability estimate instead of playing the word game. Yeah.
Well, and just kind of to play off that, something that I've noticed, especially when you go to more likely or not, is that a lot of times, at least the department's experts will, there's a distinction that needs to be made between the statistical probabilities in the general population versus with this individual child. And a lot of times, it seems like they say, well, it's very unlikely that any child would have because only 1% of children have this particular condition.
That's right.
But it's looking at that more likely than not in that individual child that is a huge distinction that sometimes you need to draw.
That's why you need a good expert to do a thorough review of the records to see whether they really found was this the one child. You bring to mind a lot of cases I've done. The one child shows up in these courts. I think I'll answer more questions than maybe. Are there other questions?
Does prenatal exposure to drugs contribute to low birth weight, and that means failure to thrive? Because a lot of the cases are all positive costs for meth or other stimulants generally.
Okay, so alcohol results in shorter kids, short stature, and smaller head circumferences, so you know that. And they could also have poor feeding from fetal alcohol. The drugs like meth and narcotics, only because the diet is so poor that the child is failing to thrive at birth and may be difficult to feed afterwards. For a kid that's withdrawing, it's very difficult. Like they have a month of fetal abstinence syndrome, and they're very difficult to feed because they're crying all the time and they're on drugs. So you have to really take that into account. Also, these kids that are born like that, from a drug environment, and weren't fed well, don't have as strong of bones, don't have as good a developmental system. All that can be factored into your cases.
So to follow up on that, other than the opioid addicted children who are actually going to be jittery and there's going to be physical symptoms, but for most of our cases, and we know very well about the fetal alcohol, okay, that's a whole other subject. But most of our cases nowadays are either, they're filing a lot on amphetamine and methamphetamine, and we still are getting the marijuana cases.
Oh.
I would assume that with the marijuana cases, if the child was born, it would be the reverse. They'd be eating, Fritos, they had the munchies from the first breath of air. But is there, to the best of your knowledge, is there any specific connection to anything that will show the use of, especially with the marijuana cases, and prenatal use?
Not that I know of, no physical factors, but the mental health factors are high. Like, why would you use marijuana throughout your pregnancy?
Because you're nauseous. Because you're fighting morning sickness, because you can't
Hey,
keep food
sell
down.
it.
I can keep going.
You didn't want to get high or change your mood, right? It's not about mood.
So if we do have, let's say, failure to thrive, and the department has a drug case, and they're trying to link, at this point, these are two separate areas that we would have to look at. Is there failure to thrive? Is there, what's the feeding? Is there an underlying pathology? But there's not necessarily a link between failure to thrive and in utero drug exposure.
That's a good question. I think it's a legal question because there isn't a medical answer.
That's fine. Not
Yeah,
having a
that's an
medical
issue.
answer may be our answer.
Again, I refer back to the mental health, even with the alleged benefit of marijuana, which is probably true, and I certainly recommend it for a lot of people, myself, that have medical conditions. It's a euphoric drug, and it's done for mood elevation. And after the baby's born, there's postpartum depression, and the person may actually have masked depression that comes out after the birth, and they can't feed the baby, they can't attend to the baby. So you still want to do a depression inventory, a survey of the person's mental health condition.
Doctor, it almost feels like what you're telling us is that failure to thrive isn't really a diagnosis.
Teach.
It's a teach.
Teach it.
It feels like
You're teaching.
maybe failure to thrive isn't a diagnosis, it's a symptom. And that too often we're letting it be treated as a diagnosis?
Yes.
Okay.
That's my main lesson.
Okay.
It's
It's a
not.
whole different way of looking at it.
It's
yeah.
actually not a diagnosis, even medically speaking.
It's a symptom and we need to be pushing to find out what the real diagnosis is.
Yes, and it's
Okay.
multifactorial.
Okay.
So it's not all lost. Oh, I have a failure to thrive case. What am I going to do now? It's about parental neglect. No way. There's a lot more to look at.
Right.
Failure to thrive is not a medical diagnosis?
It's not supposed to be. Doctors will use it. It's a.
But it's not an actual,
I'll use my exact terminology. It's not a diagnosis or a syndrome, but a physical sign of inadequate nutrition to support optimal growth and development. That's standard of care terminology from the pediatric literature.
And you're reading that from what page of your
Oh, you'll find it in there.
AKA read the whole.
And that's not to say that some of our clients don't have sophistication. We've got clients that are 19 years old, and they just may not be feeding their babies properly, and there actually may be a delay in nutritional growth. But I think then once we understand that a little better, then we're looking at it towards services, like how do you, I
Right.
mean, it's not abuse or, and it may be neglect, but how do we teach the parent
Right.
to,
It's that keyword intent. Did they intend to not feed a child? How common is intent to not feed a child versus other causes? That's using statistics another way. It's much more common to have all kinds of intervening factors resulting in failure. Okay, that's it.
Bring your evaluations up here. I have MCLE forms.
Hey Marlene, do I get to see pictures of your daughter? I remember her. How have you been?
I should really send that an email.
all